My name is Pamela Gellertley. This is my colleague Adam Hamilton, and in the next 30 minutes what we'll try and do is actually give you a broader understanding of why we think healthcare provision needs to change. What I'm going to look at is the background to the problem, the evidence and the conflict with the medical model and the medical delivery, and then come up with a possible solution. So let's look at the traditional problem that we have with managing healthcare in organisations. And I don't know what your organisations are like. I don't know, what sort of businesses that you're in, which is always difficult when you're actually trying to pitch this at sort of the right level. But in most organisations that we deal with, musculoskeletal and mental health are the two biggest issues by incidence and number of days lost and things like that, and also cost, closely followed by things like digestive disorders. The problem is most of us in organisations, we tend to use the medical model as a solution, either as part of our sickness absence provision, our private healthcare provision, sending people to physiotherapists or to CBT, when actually 80% of ill health is not a medical problem. 85% of low back pain, for example, has not got a clear clinical diagnosis, yet we're treating it with medical solutions. The underlying cause and contributory risk factor to musculoskeletal, to mental health, to digestive and many other conditions are the same. It's things like being inactive, being overweight, biopsychosocial approach, which many of you may or may not have heard of. So it's literally our lifestyle and our lifestyle behaviours. So how have we traditionally done it? And this is changing. And when I first did this slide a while ago, it was a few years, and I think we're now moving towards a more well-being approach. But our focus, because of the Health and Safety Executive, the Institute of Occupational Safety and Health, has always been on let's manage safety first. And there's nothing wrong with that, because we have to get that right. But that's probably only a small amount of our problem. And we'll look at that as we look at some data. So then what we tend to do next is we have occupational health services, which may or may not be addressing just the occupational issues. They may be looking at the personal risk factors. But then our healthcare benefits are around those medical solutions, unless you're doing something very differently. Traditionally, health and well-being has been what we've left as the employee engagement tool. It's winning hearts and minds. It's the things that we do last, not first, but luckily that is now sort of changing. So I don't know whether any of you are in distribution, but this could be a pilot, it could be a company car driver, it could be a van driver, it could be dealing with somebody actually dealing with stocks and shares, taking sort of difficult sort of financial solutions. So if we just stick with the HGV driver, from a safety point of view, we will make sure, hopefully, that they've gone and had their medical. We may have done some manual handling training, hopefully, and we may have done some other risk assessments to make sure that from a safety point of view, this person we believe is fit. But is he? He's 40, he's got a BMI of 36, he's a smoker, and you can actually see he doesn't look a very physical example. So is he fit? So what do we know about what's going on with his physical condition? I mean, certainly if you look at the amount of weight that this individual is carrying, he's putting a huge amount of load on his knees, his hips, his low back. So probably from a musculoskeletal point of view, he's not very well. Certainly probably a risk of diabetes, cardiac problems, but also how about his psychological status? He may have an EAP as a benefit, but how about if he's rung into that EAP and said, I feel like driving the lorry off the road because, my wife's just left me. We actually don't know any of that stuff, and that's because we compartmentalise safety, health and well-being, when actually what we should be doing is looking at bringing all of those things together. So let's look at some of the evidence behind this. So management information, this is just supporting what we said earlier. Now this is about cases, so it's not just sickness absence. This is looking at private healthcare claims, employers' liability claims, it's sickness absence cases, management referrals, anything that comes into a business in terms of when you're dealing with ill health. And you'll see here that most of the cases that we do, 40% of them are musculoskeletal disorders, 34% are mental health. If you just look at sickness absence in isolation, it might give you the wrong impression about musculoskeletal disorders. And quite a few of our clients have said, oh, musculoskeletal disorders are no longer an issue. It's mental health that's the issue. But actually, it's not. It's both. And both of them are actually integrated. Sickness absence from a mental health point of view might take more days lost, but from an incidence point of view, it's normally musculoskeletal that is the biggest condition, even in people that drive desks. Now, the other thing is that we talk about is work-relatedness. The health and safety executive talk about work-relatedness, and they actually rely on subjective data, as most of us do most of the time. But actually what these figures actually show, the little sort of diagrams on the right-hand side of the slide, is that a lot of work-related conditions are actually perceived, they're not real. When you actually start looking at the actual evidence, the objective evidence, it's a whole host of other things that are actually going on in people's lives that is actually in lots of conditions, and particularly mental health disorders, that are actually either the underlying cause or are contributory. But yet all the time, work gets blamed, work gets blamed. Work is actually good for us, and it's actually trying to get that balance right. So we're not saying you shouldn't look at occupational factors. Yes, you should. And how many people actually do psychological risk assessments? Health and safety requirement. Do you do it? What are your occupational hazards? Who can be harmed and how? Most organisations don't know that. But the other interesting thing and we've only put a snapshot on this slide, you then look at some of the underlying risk factors, and we've only looked at 2 here, is look at the number of people that are overweight and inactive. The overweight category that we find is pretty much similar to national statistics, so nothing unsurprising there. It's the inactive figures that is actually been a surprise, because that's not what you actually get in national statistics. Most of us are inactive. We don't move enough. And, you know, when we're overweight as well, it all comes together as a problem. So why haven't we done anything about this? Anybody know Eugene Sandow? Well, not now, because he's long since deceased. He was a physician to King George V. And he wrote a book, Life is Movement, in 1920. And basically what he said in that book, and it was a foreword to the book, where he actually said the actual physical deterioration of our nation is actually going to cause us more problems than any world war. And at that time, we'd just come out of the First World War. But what is also very interesting about what he said, look at what his recommendations were 100 years ago. He said medicine versus exercise. In other words, exercise is your pill. The importance of exercise, enjoyable exercise. Exercise doesn't have to be a bore. Heavy lifting. Now, the manual, if you look at the manual handling regs, the HSC, the European directives, they've taught us not to lift. It's an avoidance strategy, teaching us not to lift. So why is it an Olympic sport? So it's not that lifting's bad for you, it's whether you're conditioned to lift and strong to lift. But it's like our supermarket shopping. We don't even lift that anymore, do we? We all, go in our cars and our trolleys, and we don't lift anything. So as well as our upper body strength, our lower body strength actually goes fairly quickly, particularly if you're a female, because we tend to do less of it. But cycling, sleep, nutrition, all 100 years ago, and that is still very relevant today. What he's actually saying then is still relevant today. So you know this man, Sherlock Holmes? So one of the things that he said in the foreword to the same book was, okay then, well, if we physically deteriorate, that would be okay if we were then got enlightenment. Mentally, we were greater, stronger, better sort of mentally. But that's not the case. And he actually said, he quoted the Greeks, and he sort of said, physically they were a fantastic looking nation, but also they were one of the best psychologically. And I think if you go back to sort of that time, on the left we have what they actually envisaged, the two of them envisaged was the ideal body. But if you look at our national statistics now, we're one of the fattest nations we are the fattest nation in Europe. Something's gone wrong, and we've not learned. But there is a saviour, and it is called exercise. And it's actually looking at how we can actually manage our bodies, and particularly this is a musculoskeletal body. Does anybody recognise what part of the body this is? It's an MRI scan of the quad. So it's actually sort of, actually looking through. And if you take the 40-year-old triathlete, you will actually see that the bone density looks healthy. The nice piece of steak is the muscle mass, so that looks really healthy, and then the skin is on the outside. But then look at the 74-year-old. It's identical. So what that is actually saying is we don't have to worry about aging. We don't have to get depressed about it. It doesn't happen because we've got older. It happens because we've stopped moving. We've stopped being active. We've stopped doing something about it. And look at what happens to us. That 74-year-old sedentary male, that's us if we don't move, if we don't take the exercise. And I've just been in a situation with my father whereby, he's lost his ability to walk, and his life since has deteriorated dramatically, physically and mentally because of it. So what I'm actually saying is, this is, not some fad. This is about what we need to do. Our bodies were made to move. And if we move from the legs now to the heads, because a lot of us drive desks, and everybody's starting to sit up straight. But very few of us are the model on the left. Most of us now are the model in the middle. Because we text, we work at laptops, we work at computers, we drive, we do forward movements. But you can actually see that what is actually happening there is the pressure that's putting not only on the upper spine, but also on the lower spine. I've got a newer Windows First update here. Don't know what that is. Do I put on snooze? So you can but also what is interesting is how much that forward head movement restricts blood flow. So we get headaches, we get eyesight problems, our brains don't function as much. And most people start sitting up straight when they see that. How many of you heard of the biopsychosocial approach? Yeah? Basically, we've all got it. It's our attitudes, it's our beliefs, it's our fears, it's our education, it's our ethnicity. We all shape the world based on our experiences, how we've been brought up. And that can be positive, it can be negative, it can be a combination of both. So whether we're dealing with colleagues, whether we're dealing with line managers, whether we're dealing with HR or ER, or whether it's when we go to the doctors, we're always constantly trying to interpret each other and what we're actually saying. So when people have got ill health, they actually go to the doctor and they try to describe to that doctor what they think about their condition. But the doctor's also got to translate what they're actually sort of saying. And that person could be over-exaggerating, could be under-exaggerating, could find it difficult to explain, and particularly when you start getting into language issues as well. So the biopsychosocial approach is, if I move, it's going to cause me harm because I've got this low back pain. It could be work is bad for me. I mean, it could be anything, but often the psychosocial factors are an underlying cause and actually can maintain even physical ill health as well as prevent recovery. It's been evidence-based for 40 years, and yet a lot of the doctors and the physios and the CBT therapists still don't really understand this, so it's something that we've got to get better at doing. So going back a little bit to musculoskeletal disorders, how many of your people, or have you come across that go, in order for you to diagnose a condition, I need an MRI scan? If the MRI scan says I've got degenerative disc disease, then I need it treating, I probably need surgery. Well, I can pretty much tell you, all of you in this room have got degenerative disc disease. A few of you might have some disc bulges and whatever else going on. Do you know what degenerative disc disease is? Normal aging. It's normal, eh? But look at this. This is an MRI scan. So if you give people private healthcare, or they actually go to their doc and say, I need an MRI scan, the chances are the MRI scan will find something wrong, and as we age, it will get worse. doesn't mean you're going to get pain from it. So if these conditions are present, then doesn't that mean that something else is going on, and that pain is due to something else? And maybe this is part of the problem. Oh, I went quick. Why is it we take that whole person and we've got the skeletal system, we've got the digestive system, we've got the respiratory system, we've got the circulatory system, we've got the nervous system, which is linking up to the brain, and then we've got the muscular system. So why is it that from a clinical point of view, we break everybody into some sort of component part? I can't see you looking like this. And then if you look at musculoskeletal disorders, which is your biggest problem, then you go and they look at your ankle, or they look at your knee, or they look at your hip, or they look at your shoulder. Oh, sorry. But it's actually all connected. Because we're all part and parcel as a whole person. We don't function in those bite-sized chunks that the medical profession take us into. So what's the answer? The answer is what a lot of organisations are actually coming to now realise, is we have to make well-being, that health and well-being, we have to put that at the forefront, because we are dealing with people. So unless you're dealing with machines, if you're dealing with people in your organisations, we have to actually understand that as the start. And that well-being should be part of everything that we do. But then also our employee benefits. Why make them all around the medical model when 80% of the problems are not medical? So private healthcare providers, EAPs, anybody that's providing you a service as a business needs to start thinking about how those benefits, those rules, those insurances actually change to address the underlying cause and contributory risk factors, not just the pure clinical conditions. And I think we've still got a long way to go. If we do all of that, then the health and safety will be easy. And the construction industry are actually starting to put health back into health and safety. At the moment, they still seem to be focusing on the occupational issues, but we need to look at those personal issues. So in terms of integrated health, bringing it all together at an organisational level, first of all, what organisations need to do is integrate internal disciplines. So whether that be health and safety, line managers, ER, HR, whoever else sort of actually looks at health and how that's affected, then they need to come together. Then whatever you're actually doing, I mean, one of our clients had 135 different providers. They've now got us and 5 others, because what we've done is we brought it together into a model whereby everything goes through a single source, and it doesn't matter whether it's be remote case management, whether it's on-site resource, it's all actually governed together. And what we actually do is that we've got an integrated health management system that pulls all that data together, because when you actually see that data, how you actually manage the people is very different. And from an organisational, you're looking at the personal issues, you're looking at the occupational issues, and you're looking at health when they are ill and how you manage that. Because you can get conflicts of advice. So what we do is we work with the other providers to actually make sure that the messages to the individuals and to their managers are consistent, and we're always looking at actually what is going on with the individual. And coordinating the supply, whether that be a physio, a surgeon, a GP, whatever it might be, we're actually coordinating that supply. And at the personal level, that means we're actually talking to the individual, they're getting consistent messages, but we're looking at their physical, their psychological, and their social selves. At any moment in time, something can occur in your lives that actually would not be addressed if you go down the clinical route, or it might be missed, or they might send you off to several different practitioners. Whereas what we believe needs to happen is you need to actually look at an individual, find out what is going on in their lives, physically, psychologically, socially, and then address those issues, not just for now, not for the symptom now, but for the future. Ways in which we actually look at this is, and we call it touch points. So you think of all the time your employees are touched by some sort of healthcare intervention or opportunity. On employment, possibly. When they're doing their health and safety training, their manual handling, their display screen equipment, whether they go off sick, whether they're injured. There are times when you can actually assess everything to do with their health, and you can actually keep building that data. So each time you touch them, you build on getting more and more data, and you're building up a jigsaw about the individuals so you can help them in the longer term and not just the shorter term. So it's actually really looking about, from a safety point of view, making sure the health and well-being is in safety. Although occupational issues are a problem, what you cannot do is you cannot actually say you cannot ignore those sort of personal risk factors. And it's the same with health. 80% of the issues are they're not nothing to do with clinical. So why are we addressing those? And then well-being, we need to look at the whole person and not just anything else. And so what we're looking at really trying to do is actually give responsibility back to the individuals and help the individuals take responsibility back for their own health.